Fantastic. Well, let me say hello. I see a few names that I recognize, and it's nothing but I couldn't be more pleased to be speaking to my friends, peers, and colleagues here in Vermont about a subject obviously you all know is very dear to my heart. A little bit more about my background. So the 10 years that I spent in Vermont as a police officer, obviously I began to be exposed to my own levels of trauma, which was the first experience I had with what do I learn to do with what I'm seeing, what I'm feeling, and ultimately, where do we seek help? As time evolved, we began to become more and more, I think, familiar with accessing help and understanding what post-traumatic stress is. And somewhere along the lines of my career, I got a medical retirement and then went back to school and was really passionate about exploring mental health for first responders. And I started my clinical practice at Ground Zero on September 12th. And so it was truly baptism by fire. What I want to talk about is what I've learned over the past 19 years in doing this work. Now, I not only teach and speak nationally, but internationally about how to treat first responders. And I think there are a lot of myths and a lot of misunderstanding about responder wellness. And I have about 30 slides, and I want to get through this, and I want to leave some time open for questions and answers, because I think it's important for people to ask me what they may find to be important to themselves about what I may be saying today. When Brittany and I first started chatting about this, we had a long conversation about what COVID-19 has meant for a lot of us, whether we're working from home, whether we're working staggered shifts. In the first responder community, we really still are the infrastructure of all of our towns and cities, even during a pandemic year. So nobody really gets to change. If you're a police officer or a firefighter, you don't get to work from home. So these men and women are still doing this job under, different circumstances, new policies, new trainings, and we can't overlook or overshadow the amount of stress that they are under for a number of reasons. One is that they want to protect their own health and safety, and they want to protect their own health and safety of their families as well. They don't want to be exposed and take it home. So COVID-19 has really changed up the playing field, I think, for a lot of us responders. And I think the governor and the state has done an amazing job at keeping the numbers really low, which has really been helpful to our healthcare professionals who are not overwhelmed because of the low numbers. We can't talk about anything if we don't recognize the social and public unrest that's happening in our cities and small towns. This puts enormous stress, obviously, on police, but also on our firefighters. As the police are less capable of responding to emergency calls, the firefighters and EMTs sometimes may find themselves in more dangerous situations because they don't have the police protection. So the pandemic year has been also filled with really some milestone social and political and sometimes even economic factors that have been affecting our first responders. We can't discount the amount of family stress that the responders and their families are dealing with. Here at the center, we offer services to families as well, because we think it's really critical that the responder and the family really seek these kinds of services. And then we have the financial stresses. Some of our responders have spouses who may have lost jobs or who are working a decreased schedule or something along those lines. In the midst of all of this, we still ask these responders to deploy and answer the call of duty, especially if there's a natural disaster. When Brittany and I were talking, I mentioned to Brittany that in the DSM, which is the Bible for Diagnostic and Statistical Manual of Psychological Disorders, we were talking about how the authors of the DSM has listed natural disasters and man-made disasters as one of the most impactful experiences that people can have. And during these experiences, we rely on all of our emergency management teams and everybody who's under that umbrella, from EMTs to the Red Cross and so on. And what you see is that when these responders start their career, One of the biggest myths, I think, is that responders are trained to deal with stress and trauma. This was a very true statement when we were testifying in the Vermont legislature to get the law changed, because the opponents of the new law were basically saying that firefighters and police officers and EMTs are trained to deal with the repeated stress and trauma that they see on a daily basis. And from a psychological perspective, that could be no farther from the truth. Our EMTs and our first responders are trained to do the job we want them to do. So firefighters take 7 to 12 years to get somebody fully trained to know how to deal with every aspect of what can happen in a house, building fire, chemical fire, and so on. And for police officers, it's a little bit shorter period of time. But in reality, nowhere in our training do we really kind of deal with helping them understand what to do with stress and trauma when it affects them. Somewhere along the lines, they may have had a class in the basics of understanding stress. But in reality, I think everybody who joins the responder field really comes into this work thinking that they have this can-do attitude, and so therefore they will be okay. I can tell you that what I see as a therapist now for almost 20 years, that during their career, many of our first responders have some of these sayings or some of these thoughts, like thinking about what it would be like to take their own life. You know, when they feel these signs, what they think is that this must be a sign of mental illness and that therefore I must be mentally ill, but that's not true. I can tell you from my own personal experiences that I have had thoughts of suicide at points in my career, although I never acted upon them. I think what that shows you is that for all of us who want to do this work, sometimes we really get blindsided by the fact that we one day wake up and we realize that for all of the traumatic experiences we have had, that something weighing very heavily on us. And sometimes we don't know where to turn to find the right help. And so suicidal thoughts is not a sign of mental illness. It's a sign of somebody who's been affected by being exposed to traumatic events, either in their lifetime or in their career. Asking for help must mean that I'm weak. Many first responders feel that this is true, that they would keep asking for help from people in the Corps because they wouldn't want to think that, one, that they wouldn't have backup, or two, that they couldn't rely on somebody if a call happened. And so therefore, these officers and these firefighters say very little. Some people fear that if I say something, that it will hurt my career. That's not true also. It's very clear that when people ask for help, asking for help is really a sign of somebody who's resilient. For somebody who doesn't ask for help, it just shows that they're a sign of somebody who has a perspective that actually feels that if they ask for help, that something negative is going to happen to them. All right. And then this other saying is, you know, I'm better off not saying nothing, which is quite true. From the perspective that if I say nothing, then nobody will know anything, and therefore nobody ever gets any help, and the organizations don't benefit. They actually suffer by having a member not being able to continue to work in the profession. There's another thing I want to say about not being able to say anything. When people are repeatedly exposed to traumatic events, they develop a condition called alexithymic. And alexithymic means that people who are exposed to trauma can't find the words that can describe how they're feeling, right? So if somebody's alexithymic, many of the times they say nothing. And so just think how problematic if somebody says nothing when they come to work and they're not doing well, or if somebody says nothing when they're at home in their relationships, right? It really leaves both folks, whether you're at work or whether you're at home, to just assume how people are doing. You know, and in the first responder fields, you know, we have to be able to answer the call of duty at any given time. And, you know, from an emergency management perspective, you know, we may not know what those calls to duty may be. And so it's really important for leaders, managers to recognize that these sorts of sayings and these beliefs are rampant throughout the responder corps here in Vermont and actually all across the world. We have other challenges, I think, facing Vermont, and that's with our volunteer departments. Now, volunteer departments, you know, recruit members from their communities who want to serve their communities. However, they may not have the screening tools or the assessment tools to hire people who are cut out to do this kind of work. right? So when we hire members, they become part of our organization. They may have pre-existing psychological conditions. It could be previous trauma or personal trauma, a lot of grief and loss in their own lives, and they want to come and do this work. And those kinds of situations can really compromise their resiliency moving forward in this work. And so if we have a stigma around asking for help, and we believe that, if I say something, people may think I'm weak, and people come and want to serve their communities, you can see how we can have people who are working in the field who actually may not be able to handle the next traumatic event. But we really lack the resources to identify those folks and to get them the help that they need. Also in volunteer departments, because budgets are small, there's little or if any ongoing education around how to stay resilient and why understanding stress and trauma would be helpful to them and their organization. So it's really important for us to point this out, and for members of these departments, for these leaders and town managers to start thinking about, what can I do, given the resources that I have and also the budget that they have, that can help my volunteer departments be ready in case of something that would happen that they need to respond to. And the other thing is that, and this is probably one of the most important topics that we're going to talk about today, is that are these departments, even police organizations and full sworn fire departments, are they using safe and effective crisis intervention techniques? So the facts of responder mental wellness is as follows. So 3 times as many police officers kill themselves every year than who die in the line of duty. And that is in epidemic proportions. Ending last year in 2019 is the highest level we've had in over 24 years. 35% of police officers have been diagnosed with post-traumatic stress disorder. In the fire service, the numbers are a little bit more scattered, and the reason that is because that when the research was done, some of the research reports weren't answered truthfully or honestly, because the idea of the surveys were not fully explained to the firefighters who were taking them. Therefore, there's a wider spread in who has the symptoms and who doesn't. Hopefully that wasn't too confusing. But in reality, I would say that the number of 37% of firefighters is pretty accurate, considering that firefighters and police officers really do respond to mostly the same calls. What's really frightening is that 67% of EMTs report thoughts of suicide. And the reason why we don't have any firm numbers around post-traumatic stress or generalized anxiety disorder is because when you move away from the police departments, who have been more organized around collecting this data, to the EMT squads, who are less organized around collecting this data, we really don't have solid data to rely upon. And this would really raise our concerns here in Vermont, because we rely so much on these volunteer ambulance squads to provide, this really needed care in our communities. And then when it comes down to volunteer fire departments, it's completely unknown how people are doing in those squads. What's interesting to me is that one of the reasons why in 2016 we went to the legislature to change the law is because as a therapist, I began to have many firefighters, police officers, volunteer, full-time paid, it really didn't matter, and EMTs come for help and could not work. And then when we applied for workers' compensation, the insurance companies would deny the claim, and they denied the claim under how the current law was written. And the current law was written in a way that said that the stress that these responders were experiencing had to be extraordinary and unusual for what other responders were experiencing. And that made it really hard for these responders to get the help that they needed. So as Rich said in the beginning, we changed the law. The law now is that there's a presumption that the post-traumatic stress disorder was caused by work. And in these professions, there's lots of documentation that can help us prove that. There's also a second part of the law that says that any mental condition other than PTSD, depression, generalized anxiety, that is caused from a work-related issue is now compensable, and it's now compared, the stress is compared across all professions. So it made it a lot easier for responders to get mental health. Now, there's been some criticisms about changing the law. and some of the criticisms have been short-sighted. The average cost of treating a first responder for post-traumatic stress disorder is about $2,400. In Burlington, Vermont, to replace a police officer who leaves the profession, out of that year's police budget is $100,000. So it's really a cost-effective way, and it's just the right thing to do. So let's talk about assumptions about interventions. Now, I don't know if Rich or anybody has said to the audience that, am I going to answer questions during or after? I can do it either way. It really doesn't bother me. So if anybody has any questions, you can either ask them now or you can we can do them after the presentation. So what are the assumptions about interventions, right? So the most used, probably 99.9% of all departments in Vermont use what's called a critical incident stress debriefing model. This is the Mitchell model. It falls under the critical incident stress management. It's a series of interventions that are used when there's a critical incident. And the myth is that this intervention is effective shortly after a crisis situation, and it's to be used for responders who are experiencing secondary trauma. Well, in my experience, especially as a 9/11 clinician, I've done thousands of critical incident stress debriefings. And over my 19, 20 years of being a therapist, there have been probably less than 5 debriefings that I walked away and I felt good about what had just taken place in this room. And I think that's really important for people to listen to. It had come to my attention that the critical incident stress debriefings we're doing in Vermont, and I've done many in Vermont, the research that has been out for the last 10 or 15 years has said that they are not effective. As a matter of fact, at best, they're ineffective, and at worst, they can do harm to people who attend these CISDs. They're supposed to be made for small, homogeneous police. We mix police and fire together with EMS, which is what we shouldn't do. It needs to be police only or fire only. But given some of the demographics and when people can attend these things, we make exceptions, and therefore, again, they become ineffective and they could also be harmful. If you are a proponent of a CISD, what you'll recognize is that they're designed for secondary trauma. And I would agree with that assumption. But the problem, and what's not true, is that there is no longer secondary trauma in the first responder professions. First responders are exposed to primary trauma by just the nature of their job, and that's in the DSM-5, a brand new criterion that the American Psychiatric Association wrote in there, and that's criterion A4. And if you look at the research as to why did the authors of the DSM add a brand new criteria, they added this new criteria because they felt that the repeated exposure to traumatic material that police officers and firefighters respond to, a deadly car accident, a deadly house fire, is no longer secondary trauma, right? It's now primary trauma. And what they put in there is they put in there that the fact that they are repeatedly exposed and sometimes intensely exposed to traumatic material, this could cause post-traumatic stress disorder. So it's another argument as to why the CISD is ineffective and sometimes actually could be harmful. And so let's talk about why the CISD should not be used and why it doesn't work. As a trauma therapist, we learn that our minds are designed to process trauma on its own time schedule. The processing of trauma is all about the ability of somebody's mind to process the information. It's never about the blood, the guts, the gore, or the burned body. What it's about is what the mind takes in and uses as information to encode the memory and to put it in a positive memory network. So what happens with the CISD is that we gather people into a room, we sit in a circle, and we ask people to go around the circle, and we call it a structured conversation where we're going to help people process through this traumatic event. The problem with that is a lot of people may not be ready at that moment to process through that traumatic event, right? So if we force people to revisit a traumatic experience that's currently overwhelming their ability to cope, right? That's where we can do some harm, right? as human beings, we have a mind that is naturally resilient. So when we take traumatic events and they overwhelm us, the mind sticks them in an amnestic network, so a network of memories that has some amnesia with it, right? So the mind wants to actually forget it. What a CIS does is it forces people to come and it forces people to listen. Even if you don't talk, it forces people to listen to the information about a specific traumatic event, right? So that's where we feel that it interrupts what's normal about how the mind processes trauma. The other thing is that an acute reaction to a stressful call is actually really normal, right? And that's why the DSM has acute stress disorder. And the acute stress disorder is good for 30 days. And so again, we want to recognize what is natural in human beings and for their ability to process through traumatic events, right? And the reason why it doesn't work also is because it's designed for vicarious trauma, not primary trauma. And I'm going to go to the DSM in a few slides from now. We're going to see what the DSM says. So for those folks who may not be believing what I'm saying or may find this to be quite confusing, when I did the research and I found other documents that kind of talk to why should we not use the critical incident stress debriefing model, I looked at some of the research that came out from the National Institutes of Mental Health, the American Psychiatric Association, the U.S. Department of Human Services, Department of Defense, the Veterans Affairs, the Red Cross, and all of these organizations are recommending that we do not use the CISM and the CISD model. Right? The World Health Organization also recognizes that the CISD forces people to share information where at times in their own recovery, it may be harmful to them. So I think it's really important that we rethink what our interventions really are. And here's the DSM-5, and you can see this is exactly what the criterion A4 says. It says that the repeated and intense exposure to traumatic material, right? And they use the example of police officers being exposed to the aversive details of child abuse cases. Now, I just want to focus on that for a second. What the DSM is saying in the American Psychiatric Association, what it's saying is that an officer in the course of their work who writes the details of a child who's been abused onto a computer can develop post-traumatic stress disorder. So there is no longer vicarious trauma, right? And it also uses first responders collecting human remains. And so this really brought to my attention the fact that the CISM doesn't work because the fact that first responders are no longer exposed to what we believe we have previously called vicarious trauma. And why is that? So let me get into a little bit of the brain science. So we have two brains. We have a left brain, which is our logic thinking brain, our brain that does our critical thinking, our judgment, and our reasoning. And we have our right brain, our emotional brain, or one other thing we can call it is our survival brain, right? In the midst of a stress response, right, the emotional brain is like an iPhone 50, and our rational frontal lobes are really like a flip phone with an antenna. So during a stress response, the emotional brain becomes the more dominant brain. The emotional brain actually deactivates our rational thinking brain. Now, just think about that for a second, right? How do we function? How do first responders be able to, still do what they need to do? Well, what happens is that first responders become very task-oriented in the midst of a critical incident, right? And the reason why they become task-oriented is because we train. We develop in that rational thinking brain what's called implicit memory. So the more times a police officer practices a technique, the more times a firefighter or an EMT practices what they need to do, that memory circuit becomes wired. So in the midst of an intensely traumatic event, we can still function. But think what I'm saying, right? So even as the emotional brain may be overwhelmed, we still require, and we still do, ask our first responders to do this work. And the reason why they're capable of doing that work is because we've created what's called an implicit memory for them. You can think of implicit memory as riding a bike or tying your shoe, right? You can have a complete coherent conversation with somebody while you're tying your shoe because you're not even thinking about tying your shoe. Well, as a trauma therapist, this can become problematic because we can become overexposed to some of the experiences that we have without even knowing it. That being said, leadership plays a really important role in helping our first responders be prepared and also be resilient throughout their career. One would be, before a critical incident or before a natural disaster, establish a mental health response policy. Now, this is a little bit different than a mental health policy that an organization may have. So a mental health response policy is a policy of how we would respond, who would be the players that we would have to be involved with, and what that would look like for our organization, right? So what that looks like is providing psychoeducation for supervisors and staff before and after a critical incident. So psychoeducation is any number of topics, from understanding stress and trauma to preventing suicide to suicide prevention. And as you can see in these professions, that we're no stranger to suicide, right? Another really key important, probably one of the most important factors, is identifying a qualified mental health professional to work with you and your organization. Now, I can't stress this enough. Now, there are lots of good therapists out there, just like there are great primary care physicians. There are also physicians who specialize in, cardiology or plastic surgery. There are also mental health professionals who specialize in trauma. And what's unfortunate is that to become a licensed professional, you don't really have to have a specialty in anything. However, when we experience a natural disaster and we want people to come and help our organization, we want people who understand what it's like to experience traumatic events, who understands what it's like to work with an organization, especially within incident command, right? And to understand what it's like to treat traumatic stress and to provide relief to folks. In 2019, after the El Paso shootings, I was called by the FBI, and I went down. I talked to them in Tallahassee, Florida, at one of their regional training centers. And what I learned was that even the largest law enforcement organization in this country didn't know how to access the appropriate resources. Now, they have everything from, all kinds of vehicles, all kinds of armory, but they didn't know where to turn to provide the best mental health response for their agents who were in the Walmart in El Paso. And so this is what I'm talking about. You need to be able to identify these folks prior to these experiences happening, and connect with them, sit down with them, and get this emergency mental health response plan to work, and get everybody on board the same page. You also have to be familiar with the responder profession. So many times I get responders in here that say that they tried therapy. They may have tried it through the avenues that are afforded them from their organizations. And they say that, the person just didn't get it. Like, they may not know what it's like to do CPR on a 2-month-old. And therefore, the responder feels like, I don't feel like I can open up to this person. And I think we only get one shot at providing mental health for responders who are first seeking mental health. And if their first impression in going to a therapist and asking for help is not positive, I think it hurts us all in the long run. And I think we really need to be mindful of that. So to do this work ahead of time, I think is really important, right? So the role of leadership, right, is to identify and coordinate other resources in your community other than a mental health professional. You talk about having massage therapists, acupuncturists. By the way, acupuncture is paid by insurance. You just got to be able to get approval ahead of time. Massage and mindfulness practices aren't, but here at the center, we utilize all of these practices, especially during a workers' compensation case, to get first responders back to work as quickly as possible, right? So what can we do before a crisis happens, right? So education and training. The center provides education, and for a lot of our organizations across the state, they may not have the ability to pay for us to come out, and so we come out and we do it anyway because we feel it's one of the services that we want to give back to our community. So it's important to recognize that this type of education can go a long way. We can, talk to a group of people, and somebody can say, what you said really struck a nerve with me, and I figured I'd give you a call and maybe see if I can come and talk about this. A lot of our respondents, believe it or not, don't know where to turn. Right? They don't know how to make sense out of what they've seen and what they've recognized throughout their career, right? Another important aspect of training is training our supervisors to recognize the signs and symptoms of stress and trauma. And, and how do you recommend or make a referral for somebody in your organization so they can get the help that they need? Especially at a time when, with EMDR, which is the kind of trauma therapy that I use, which treats trauma so effectively and so quickly, it's really something that people should think about. There's a tool out there that our members can get help quite quickly. Establish a peer support team or a peer support or a buddy system, something in your organization where you have peers looking out for peers. It's probably the best and the gold standard in the professions because it's really cost effective, doesn't cost much money to keep a peer team up and running. And peers are the ones who understand what the job is like, and they actually can really perform the day-to-day support work that other peers may need. The buddy system goes way back in these professions where, after a shift, we may all get together, we use alcohol, obviously, and to help us calm down or go to sleep, and but in that buddy system it's really important that peers look out for peers, and I think that's been something that's been a constant in these professions for a really long period of time. Use safe and effective interventions. And so, you just heard me talk about how I believe the CISD is not effective, and it's used all across this country at an alarming rate. There is a safe intervention that we do here at the center. It's based in all of the theory and the protocols of EMDR. It's called traumatic stress relief. And EMDR early interventions. And what are these? Well, traumatic stress relief and EMDR early interventions are both prevention and treatment techniques that we can deploy and use shortly after a crisis event, just like the CISD. But there's a lot of difference between the two. One, the TSR training involves a lot of grounding and stabilization for the individual, which is one-on-one, which is done immediately after the event. And so we would come out, we would talk with your folks before they go home and before they even get into their first sleep cycle, because you realize that our sleep cycles is where our mind tries to consolidate our events into memory. And if a person goes home with a negative belief of thinking, I didn't do enough or I didn't drive fast enough, we would not want that negative belief to be consolidated into a maladaptive memory for that person. That's how post-traumatic stress starts, right? So TSR training and the techniques are immediately after an event. And then what is similar to the critical incident stress debriefing is the EMDR-EI group traumatic protocol. This is a group protocol that is done using this worksheet where you can see that people sit at a table, people are silent, everybody works on their own sheet, and we start off by a grounding safety exercise. We start off by doing what's called a resourcing or positive memory exercise. Then we have them, in the third box, we have them think about how they'd like to see themselves in the future. And then in step 4, we have them assess themselves, right? So if you're 0 to 3, you probably don't need to go through the rest of the trauma reprocessing. If you're between 4 to 6, you can tolerate some additional trauma reprocessing. And if you're a 7 or higher, it's not safe for you to engage in any information about the traumatic event, right? And so we take a break. And then we would assess everybody. And for those folks who would be 7 or higher, we would make the referral for them to see a certified EMDR therapist and follow up with them the next day. For those folks who stay and want to process the traumatic event, we have them identify in the middle of this big black arrow what really is the point of disturbance. And what we're really doing is we're using all of the EMDR techniques to desensitize the emotionality of the most recent traumatic event. And we do it through these 3 boxes, right, where we utilize the core element of EMDR, which is the bilateral stimulation of the emotional brain and the rational brain, which is the same technique that takes place during REM sleep. And we have we have responders work through the traumatic event until we get down here and we measure in these circles their unit of disturbance, like how emotionally disturbed are they. And you can see if you go up to step 1, we take one before we do any mindfulness exercise, we take one after, and then we watch the SUDS, as we call them. It's just like a pain scale, 0 to 10, 10 being the most disturbing. We watch these SUDS decline as they go through a series of processing the event. And then on the bottom, the last one, we ask them to notice if there's a negative belief they may have had about themselves, right? And then we ask them to test the validity of that belief. And what this does is this allows us to actually treat the traumatic event. Each person is silent. They're treating it by themselves. They're experiencing their own experience, and we're actually doing trauma work in the midst of a group protocol. So the GCHAPS allows for the natural processing of the traumatic event. It's totally safe and totally effective. We would never let anybody who would be a 7 or higher go forward. It's used as a screening tool. You can use this for large or small groups. I can put firefighters, police officers, tow truck drivers, dispatchers, all in the same group, because nobody is speaking out loud and nobody is sharing their own experiences with the group. Nobody shares information, and we can lump everybody together. And what that does for an organization allows us to really be able to deploy and use these group interventions really quickly. Now, what I've left here in the resource section is a bunch of more information about the EMDR early interventions that people can go to. I'm going to send this PowerPoint off to you folks so it can be disseminated. I also have the services at the center here that we offer folks. And then I also have the research on the critical incident stress debriefing, and I want people to make their own decision about what you feel would be effective for your own folks. And Rich, I am done with my presentation. Not quite sure if I have time for questions or not.
Absolutely, and Sonny, thank you. So those that don't know me, and I'm sure probably half the room does, I'm also a firefighter in the volunteer service and an EMT. I've been doing it for 18 years. So to listen to what you say, I've gone back to the old CISD things that we've gone through, and I've sat through I don't know how many of those. And what you said is so spot on and accurate, and just, yeah, it didn't work. I'm sitting in a room with my peers. How many of you are having trouble with this event? And, I'm the only one that raises my hand. It doesn't work. So thank you so much. So some questions came up in the chat. What are resources for family members of first responders to both learn how to help the responder and their needs, but also to help themselves to be able to cope with the responder's concerns?
Yeah, so I think first of all, the first responder, whether a volunteer or fully paid and sworn, should know what the resources are, right? Should go to human resources in their organization and find out what's available. I would say that EAP is available to every organization in the state. I could be wrong, but I think that's accurate. Right? So EAP is a resource. What you may find is that responders may not find EAP to be the right place for them, but it may be the right place for their families, right? So our spouses, our children, especially if you're doing anything in policing these days, families are really under stress worrying about their loved ones going to work. So you can go to our website, vtresponderwellness.com, and we have a link with all kinds of resources we want people to take advantage of. And, if you want, you can also call the center at 661-HERO, HERO, and we will give you resources that you need, especially during COVID. COVID was a very interesting 6 or 7 months because we couldn't be on site. We were sending out boatloads of resources in newsletters every month to all of these organizations. So you can go to our website, and you can also get on our email list, and we will send you our newsletter every month, which has all kinds of resources on it.
All right, thank you. So, folks, this is your time to ask questions of Sonny. We have 18 minutes or so till technically the end of the conference, but I'm willing to stay. I don't know if others are. So feel free, you can unmute yourself, you can type questions into the chat, and we'll get them addressed. And while you're formulating some questions, Sonny, I have a question. I'm down in the Brattleboro area. I notice you're up in Colchester, about 2.5 hours. So obviously, if someone on my department or in my area needed something from you, it's a little bit of a gap in distance. What resources do you have in other parts of the state, or how do we find resources in other parts of the state?
So, Rich, one thing the Department of Health did is that they allowed us to use Zoom, right, as an acceptable form of support and as a resource. And so we can actually bill, so you can use your insurance to get connected with us through a HIPAA-protected platform called Doxy. And we can support first responders now all over the state. We also have peer specialists. So we have people who are retired from the service, firefighters and police officers, who go around the state, doing peer support. So organizations who don't have peer support teams, we provide peers who are trained to support those folks. So a member of your department, if they had an issue with leadership, or they had an issue about, I feel like I'm on probation and I'm not going to pass and I'm going to get fired, and they wanted to talk about maybe a technical thing, they could contact one of our peers and talk with them about, what is it that I can do to work around this issue that I may have, or even a personnel issue. Like, I'm having troubles with the people on my shift, right? I feel like I feel like I'm not good enough, and whatever it may be, right? So peers are great in those kinds of situations.
Thank you. I appreciate that. So thank you very much for letting us know about that. Other questions, folks?
Sonny, this is Todd Manise, and I've been to the website during your website during your presentation. What do I use for an email to you to have a discussion further? Our river management engineer jobs are very stressful.
Yeah, so you can contact me directly at cop to cop. That's COP, the number 2, COP, cop to cop at hotmail.com.
Thank you, sir.
My pleasure.
Sonny, this is Stacy Pomeroy. I haven't had a chance to look at your webpage yet. Are there also resources on how to help I guess first responders or other public folks work with people who may have experienced traumatic impacts? As Todd mentioned, our stream engineers work with a lot of folks after flooding who may have experienced trauma from that flooding, loss of their home or impact to the town. So we often are not I guess in some ways we're a first responder, but we're dealing more with the folks who have had that traumatic effect. So how to work with them to make it less stressful. Are there resources on your page that you might refer us to look at for working with the public after a traumatic event?
Yeah, so the traumatic stress relief training that I talked about, if you can follow me in the history here. So Francine Shapiro created EMDR in the late 1980s. It's been used for natural disasters all over the world. It's actually where the group protocol really got started. Francine Shapiro's dream was to train paraprofessionals, non-licensed people in the EMDR techniques because they're so effective. So in last year, Francine died, and I was invited in Geneva to be trained as 12 trainers to train people in the United States as paraprofessionals. So in Vermont, we have 50 police officers who are trained as EMDR paraprofessionals. And so the traumatic stress relief training, we can train anybody to use these techniques, right? And they're techniques that are based in stabilization and grounding, like breathing and mindfulness exercises and containment exercises, all of the core exercises that an EMDR trauma therapist uses with their client prior to processing the trauma. And so it's just a set of skills and techniques that we use. All of our peer teams that I work with organizations use. They use it on their peers, and this would be a great training to attend, so you would know how to interact with people, especially moments or days after a traumatic event where you're trying to interact with them and you realize that they're really struggling from what had just happened.
Great, thank you for that information.
Yes. Hey, Rich, I have a question.
Yeah, go ahead.
How many people have attended the conference?
So right now I'm looking, we currently have 57 attendees here at this moment. And Brittany, if you're on, I see you're up as one of the presenters. She said we had somewhere around 100 people registered each day, so today and tomorrow.
That's amazing. And if you could tell me who really is the population of the folks who are attending this conference?
We have a wide variety. I'm looking down the list right now. So this conference is geared to emergency management partners in Vermont. So we're talking about local emergency management directors, people that are appointed by their board, their select board or governing body, to be the emergency management person in their town. We're also looking at some volunteers or career fire, police, and EMS. We have some folks from Agency of Transportation and their transportation partners in the community. We have other state employees, so a lot of folks from Vermont Emergency Management who have been working this COVID-19 disaster pandemic since it started. And just looking through the list, yeah, a lot of just folks that have been involved in all phases of planning, response, recovery, and mitigating disasters that have happened here in Vermont.
Right. So, it's interesting. I love the fact that this was so diverse, right? And we have all of these folks who are part of their community and want to serve their community. What I feel is really a gap in from a psychological perspective is letting people know what the resources are, right? So the EAP is for everybody in the state. That's a tremendous resource that we have. And although people may feel like, if I work for VTrans and, I may have seen something on the highway or something, whatever it may be, I want people to recognize that if they have any questions about, their own level of mental health, they can call the center and ask me or ask one of my staff. We have 7 different therapists that work here. So we're a ton of resource for everybody in the state. I don't want a town manager or somebody in a local town somewhere to feel like they don't know where to turn. When I did some work after Sandy Hook with the Colonel of Connecticut State Police, and here's a person who has tons of resources in a state that has lots of money, and they didn't know where to turn, right? 1 week into the tragedy at Sandy Hook. And so I just want to make sure people recognize that, we are a resource. You can call us up, think of us as 211, right? But in a different capacity. We can steer people in a direction of finding help. And for anybody who wants our newsletter, we're happy to share it with you. You just got to go to the website and just click on, click on the email piece, newsletter, that's all.
Thank you. And another question popped up in the chat is, what advice do you have for emergency managers who have been working this crisis for months? And we're looking at managing it for some unknown amount of time going into the future.
Yeah. Wow, that's a great question. As therapists, we're still trying to figure out what COVID is really doing to us, right? Not to me, but to us, right? How to provide the best help possible. And one of the things I think is important for people to recognize is, it's harder to work from home. It's harder to sit at my computer in my house when my refrigerator is 20 feet away. It's harder when my dog wants to bite my leg as I'm trying to get my work done. And I think it's important that managers recognize that it takes more energy to get my work done, and I'm only getting half the work done. And some of us may feel guilty, taking a break and getting a cup of tea and going out on the back porch and maybe pulling some weeds, right? I want people to recognize that this COVID thing requires us to think outside the box. I had a state trooper who came to me and said, I'm really, really stressed out. And I said to him, well, tell me what's going on, right? And I don't know, I got all my casework done and like I have all this stuff, working from home. And I said to him, are you worried about somebody driving by and watching you cut your lawn? He says, damn right I am. And do you feel like that's, he says, yeah, I feel like I'm guilty. And I'm like, guilty of what? And he says, I don't know, beating the system. And I said, listen, if you're worried about that, call your boss and say, hey, listen, this is what's going on for me. And, would it be okay if I took a break in the middle of the day and I did something, went to my garage and worked on my old dresser? And he says, oh, that's a really good idea. I said, yeah, because think how stressed out you are. First of all, some of us are working from home and we may be getting all of our work done. And so therefore, it's easy when I'm at the office and I have to put my time in. But when I'm at home and my work is done and I don't want, so there is this built-in stressor here that we're not paying attention to. And that is, this requires us to think differently about how we get our work done. And if anybody has a question, you have to talk to your manager or your supervisor about that and make sure that we're all on the same page, and therefore we can alleviate the stressors, because we can work ourselves to death under these circumstances, and we're recognizing that the work is much harder to do, and I'm more tired at the end of the day. And if I'm more tired at the end of the day, I'm less present for my family. And if I'm less present for my family, that creates issues. And if I feel like my work is not getting done or it's not the same work product, then I feel like I'm not good enough at work. And it creates this whole, this debacle of what, how we really deal with stuff. These really do require us to think differently about the workforce and how we get work done.
Thank you. Thank you for that. Other questions, folks? All right, I'm not.
Rich, I have one question. This is Brett.
Hey, Brett, go right ahead.
Yeah, this was very interesting. I enjoyed your presentation very much, so thank you. You spoke a lot about emergency responders and the challenges they face. As a first responder, that time management piece, access to resources you may need, time. These volunteer folks, these paid call folks who are wearing a pager on their belt and have a full-time job, have families, have, school plays and sporting events and camping trips. They're fitting in their minimum training requirements, to keep that certification. It seems that in order to put the emphasis on the mental health piece, that piece somehow needs to be incorporated into that basic training. That is an annual recertification requirement. You must, get a couple hours of continuing education in this each year. Just, an awareness thing, just like we have to do hazmat refresher every year. So we can say we didn't forget our skills. It just seems like something like that needs to be built in, because otherwise it just becomes another thing that you just don't have the time to do. When people are prioritizing the minimal time they have, the mental health piece, because it's not a requirement, gets pushed to the side.
Brett, you are so right. And it seems so simple, doesn't it?
It does.
Right. So we're working at this in Vermont for over 30 years, and Vermont, believe it or not, is one of the states that is ahead of a lot of other states in terms of some of our policies and some of the initiatives that we have in some of our responder organizations. And you're right. So the larger organizations can sometimes make the commitment because they have the people and they have the money, right? But the smaller organizations can't. And so, I think what's important is what does this really look like? So, you have people coming in. Can we do this in a half hour? Can we do this in an hour? Can we give people the nuts and bolts of how to stay healthy, like how to find balance in your life? Absolutely. You totally can do that. But here's the warning. It's got to be the right person, because within 10 minutes, you're going to lose them. So you have to invite people such as myself who have walked the walk and have had the experiences to kind of grab their attention and pay attention. Sometimes if you bring in just a local therapist and there are a lot of local therapists who want to donate their time, believe me. I think in Brattleboro, there's actually a really good therapist. I'll get you his name, Rich. You really have to bring in the right people so your people pay attention and so you can make the best impact as possible. But what you're talking about, Brett, like minimum certifications, there are more people who are dying, right? Like the numbers of people we're losing every year in these professions we're losing them because of mental health. Think about what I'm saying.
Yes, absolutely.
Yeah. Yeah, and Vermont has done a really impressive job. We just need to do better, and like inviting me is one way we always do better, like one more opportunity to get the message out there. And, I met with a town manager about a year ago, actually 2 years ago now I think about it. They have, they obviously have rescue and fire and police and all that. And the town manager said to me, what would it cost to provide the best, like when we have a health insurance policy, you have a choice, right? You have the gold standard and then you have others, right? He said, I want to purchase the best for our responders. And so we did that. And what he did is he sent the message to all of his responders. This is a resource that we have. I would want people to take advantage of it and their families as well. And what that has done is that has opened the door for people to stay healthy. And I have senior members coming to me and say, listen, I want to stay healthy, right? And this just happened the other day, and we process that stuff as soon as it happens. Now, everybody doesn't have that luxury, right? But what I am saying, Rich, is that if you're in Brattleboro and you have a volunteer peer who's struggling with something, you folks should call us and just say, hey, listen, what does this look like? It could be a 20-minute phone conversation. It could be a 20-minute Zoom conversation. If I think that the person really needs help, I know that the Uniform Services Program in Brattleboro is not currently open. Right, so we have to be aware that that's not currently open. There is a resource in Western Mass called McLean Medical Center. They have another first responder program. And by the way, when I talk about first responder programs, I could make the argument that anybody in emergency management is a first responder. And why do we have these separate programs? We have these separate programs because we all experience in that same level of trauma. What folks did after Irene was just, mind-boggling to me as a therapist, right? But the stories of the volunteer firefighters of swimming underwater, trying to save people was what we do. And that's why we have these specialized programs. And so, we created the center because it's a place where we want responders to feel like they can come and talk about what's going on for them. And so, just like any consult is always like we would talk to anybody and push them in the right direction to get them help. So, Brett, to answer your question, if you're in charge of an organization or a fire department somewhere, we'd be happy to come down for an hour and talk to your members about how to stay healthy. And maybe we got to buy them pizza to stay the extra hour.
It works.
Yeah, no, absolutely. And and that's the commitment I think we all make. We all say, listen, I can only show you, I can bring you to the water hole, but I can't make you drink, right? But that one person who may remember a presentation may pick up the phone when they need to, and that could be all the difference in the world in that person's life.
Yeah, no, that's a great, and certainly something I would offline would like to have a conversation about. And I know you're past your time. It just one last comment is or question: when you have the volunteer services, emergency services organizations, and you cross paths with folks, so few times. Well, depending on your organization, like the organization I belong to, where you run 150 calls a year. So you train together a couple times a month, maybe you get half the department of the training. You might see a few people at a call here, a call there, but your interaction with them is really, in the big picture, in the course of a day, in the course of a week or month, is so minimal. And are we the emergency services organization? I mean, where's that line? Where do we start taking on this responsibility, when things could be coming from somewhere else? I just think that's a really gray area.
It is, and I think part of the education piece is, I had many more slides, and it was about resiliency, and I just kind of take some stuff out. But one of the slides I had in there talked about, a resilient person, knows when to ask for help and gives themselves permission to feel and to say, hey, I need some help. And so one of the other slides talked about that a resilient person, seeks help from their community, from others, not I'm going to do this alone, right? And so I think it's really important in the education piece to put that message out there, right? That, listen, you can rely on your peers, but, your peers need to know when to hand it off to somebody who, may be better suited to deal with the level of what somebody may be dealing with. And, we're all, none of us are immune to the harmful effects of experiencing traumatic events. And I just want people to recognize that, trauma is all about our mind's ability to process the information and to encode the experience, and so we can integrate it into who we are as people. And so what I think is really important is for responders to know that, one, there's people out there who gets this stuff, and two, there are people out here who really specialize in helping them feel better, and their families. And I think that's something that's really missing. And I'll just keep going back and back and back. During the Boston bombings, the MIT officer who was shot and killed, I saw the chief of MIT at a conference a year later, and I asked him, hey, who helped your organization? And he said, nobody. And I said, what do you mean nobody? He said, I didn't know who to look, who to turn to. The chief at MIT used to be the colonel of Mass State Police. Now, if that person did not know what the resources were, right? So it shows you that even in a state that's larger and you think there are more resources readily available, you come into Vermont, the resources are even less, right? So when we're not really readily available. And so, it's great that you are bringing in people like myself. We can talk about the services that we have. And by the way, none of what I want to talk about today is about bringing this center any business. It's about letting people know that there's a center here. And I just said this, that we'd be happy to come to your location and provide this education and training for nothing. It's what we do. We have organizations that support us. So I want people to always know that there is an organization here that has trained therapists and peers in the responder community who are willing to come out, educate and help and be a resource. And God forbid, something tragic happens, we want to be able to provide the kind of help that would be really helpful.
Sonny, thank you very much for that insight and for the information. I certainly look forward to the opportunity to speak with you further.
You too. Please get a hold of me.
Sonny, thank you for presenting today.